if there's time for questions after, everyone can just speak loudly into the room. Is it recording? Okay. Okay, so I'll introduce our speaker, Hussam Jefee-Bahoul. He is assistant professor at University of Massachusetts Medical School and an addiction psychiatry fellow at Yale School of Medicine. He graduated medical school from Tishreen University in Syria in 2006 and moved to the USA in 2009 to start adult psychiatry residency training in the University of Texas Southwestern in Dallas. He moved to Yale School of Medicine in July 2013. His academic interests are global mental health, refugee mental health, cross-cultural psychiatry, and the implementation of telemental health in conflict and disaster settings. He conducts research in the USA and the Middle East in collaboration with Dr. Andres Barquil-Oteo, and we're excited to continue our collaboration with Hussam, as he was the keynote speaker at last year's symposium. So we welcome this opportunity, and we're grateful that he's here today. So I think you can start now then.
All right. Well, thank you so much for having me. Do you hear me all well? The sound is good?
Yes. Yep.
All right, excellent. So let me go ahead and start the presentation. So, the topic that I'm going to talk about today is dear to my heart. It kind of it connects a lot of my interests together. My interest in technology and the role of technology, and how has it really been affecting our lives on a personal level, and also as a society and as a species, in the last 20, 30 years, and also mental health and kind of resource limited settings, and how can this technology really bridge the gap. I'm going to talk mostly about the Middle East today, and and some of my personal work in Syria as an example. Today's talk is going to be divided on four portions. At the beginning, I'm going to be talking, I'm giving an overview of telemental health. What does that mean? What does it entail? Then a little bit of an overview of the Middle East, the mental health issues encountered in the Middle East. Then we'll review a little bit of the telemental health reports from that part of the world, and I'll finish by covering a few slides over an example of my work in Syria. So, when we say telemental health, it's a branch of telemedicine. It's one of the rapidly expanding branches of telemedicine. I think teleradiology is another branch that is going fast, and teledermatology is another also rapidly expanding branch of telemedicine. So in a nutshell, it is really the use of technology to provide any form of mental health service, whether it's your basic psychoeducation, using the technology to provide psychoeducation, to the more comprehensive interventions like cognitive behavioral therapy, or diagnostic consultations, or training, or the use of technology in doing research. So the way I think about the applicability of the technology is especially in the medical psychiatric realm, it's in four domains: either in patient care, either in consultation, or training of staff, or in doing research. And to do any of those things, you can either use a real-time, live, synchronous technology like what we're doing right now. We're doing video conferencing. You're seeing me live. We are in two different places. Or we can do a store and forward asynchronous work. An example of that would be if we corresponded by email. That would be the simplest way, or if there are any kind of static platforms that allows us to transfer data or information between two ends, but not live. So that's kind of under that, the mobile health apps can fall under this. especially if there are no direct interaction between two parties. So that would be under the store and forward. But if we're using an app that has immediate interaction between two parties, then it will be more on the live and the real-time interaction. So you have two main categories: live or store and forward, and there are 4 domains where we can apply any of those two: patient care, consultation, training, and research. This is in general how I think about telemental health. As I said, it can be a video conferencing, or it can be an email secure platforms to provide any of the above. And I'll go about describing few examples of these applications in the Middle East, since this is the area that we're talking about today. Now, just keep in mind that any of these areas of telemental health has been rigorously studied in the US, in Australia, and the UK. So we have an abundance of literature research about the applicability, the acceptability of these interventions, the efficacy of these interventions in different populations, mostly in the Western hemisphere of our world. Unfortunately, in the low resource limited settings, things get a little bit dicey, and the Middle East is no exception. So the Middle East is as you know, I mean, there's really no distinct definition of which areas are consistent with the Middle East or North Africa. Sometimes North Africa is considered part of the Middle East. And honestly, to me, this term is really, have all of the connotations of the post-colonial, division of the world. So I usually don't like to use it that much, but for the purpose of the academic work right now, I'm using the Middle East to refer to this part of the world that includes Egypt, the Gulf region, the Levant, Syria, Jordan, Palestine, Israel, Iraq, Turkey, and Iran. So we're not going to talk about North Africa today. So the Middle East is a very complex region. It's rich with history, culture, tradition. It's one of the most probably volatile regions in the world nowadays. A lot of conflicts going on, and mental health is really one of the major public health concerns over there. But as we will see, it's probably one of the least attended to among the other public health issues. So if we think globally, the lifetime prevalence of any mental illness is about 29%. 1 in 5 people, about 17%, having experienced mental illness in the last 12 months. And this is exactly what we will see in the Middle East. So basically, the Middle East is not different than any other part of the world in regards to how prevalent mental health issues are, and also the presence of conflicts, which would make things a little bit more intense. Now, these are just few examples from 3 countries: Iraq, Lebanon, and Israel. The prevalence is about 18, 17, 18%. So it's not different from the global estimates.
Hello, Hussam? Hussam, do you have slides up?
Yes, the slide is up. You don't have it?
We don't have it.
No, it just disappeared. We had it until a minute ago.
Just the map of your defined east.
We're doing some checking on our end. Hopefully we'll in a minute.
Yeah, it says become the presenter to start. So I need to be assigned again as a presenter.
Oh, okay. Oh.
I don't know how it got dropped.
Speaking of telecommunications.
Still see my video?
Yeah, I remember Steve shared it so that you could be a presenter, and I think that access was lost somehow.
So speaking about technology, this is one of the many kind of difficulty, especially doing clinical work with this, is a little bit difficult.
Can you see us, Hussam?
No,
Oh, we can see you and hear you beautifully.
now I can see you. Now I can see you.
Okay, but we can't see your slides, so I think that's, we'll have to
Well,
try.
I need to be. I guess I need to be assigned as the presenter.
Right.
Um,
I'm trying to do that, but we're finding that out.
Yeah.
So. And
Not sure how.
we've got someone, that we're texting who's gonna help us out.
But you were explaining the percentages and so forth fine, so we're happy for you to continue your talk.
Right.
Yeah. So we can. If you want, we can continue to talk until we get the slides up. I mean, I was just. So yeah, I was talking about how the Middle East is not really different than any part of the world in regards to the prevalence of mental health problems. It's about 17 to 18%, and of the population large that experience any form of mental illness in the last 12 months, basically. That's kind of the main estimate of mental health in the region. Now, another thing that we usually look at when we're comparing globally different populations, there's what is called the global burden of disease. I'm not sure if you're familiar with the terminology. It has been emerging as a more popular way of estimating the burden of illness, whether it's cardiovascular illness, whether it's cancer, whether it's smoking, whether it's globally, and mental health or mental illness is one of the leading causes of global burden of the disease. For example, when they looked at the Middle East, there were studies from 2013 and 2014 that have been published in the Lancet about the burden of different mental illnesses in the Middle East. Major depressive disorder was the leading cause of years lived with disability. That's the YLD measure in Jordan, Syria, and Palestine. So you have major depressive disorder, kind of the leading causes of disability in a way in those countries. And then you have and major depressive disorder being the second leading cause of disability in Iran, Kuwait, Lebanon, Oman, Turkey, the United Arab Emirates. So it's okay. Here we go again. I guess. Do you see it again?
Yes. Yes.
Yes.
So this is what I was just saying. The global burden of disease and the lived with disability indices that have been used recently in trying to estimate, the weight of each illness and on a population level. And mental health issues are obviously one of the leading causes of disability in the region. So combined with these numbers that I was talking about in the slide before, you have some kind of a sense about how how burdensome mental illness in the region, in the Middle East, which is in a way similar to other parts of the world. Now, what is really striking about the Middle East example is the gap between the demand and supply of care. So we have high numbers, significant numbers of mental illness. We have a great burden, but we don't have many resources. So the majority of the region, and it's the rule, not the exception, suffers from poor allocated financial resources for mental health issues, lack of manpower. There isn't really any infrastructure, and I'll show you some numbers in the next slide. And also, kind of even on the political legislative level, there's not much of an advocacy for mental health issues. It's kind of on the bottom list of the agenda. One example, like the Eastern Mediterranean, which is Syria, Iraq, Syria, Lebanon, Jordan, Palestine. You have 0.27 outpatient facilities for 100,000 patients. So basically, you have about one clinic for about 500,000. I mean, you can just ponder on that for a second. And this is, I don't know if the slide is clear to you on your screen with the numbers. I apologize if the numbers are small, but these are 5 indices adapted from a paper by Jacobs et al. In Lancet 2007. And I think they are about to publish an annual update on it. We don't have an annual update yet, but I'm not sure how much things has changed in the Middle East in 2007. If not, things got worse, I would say, in some parts. So we have five columns, proportion of mental health budget. Not most countries have reported on that, but the striking numbers come with the number of suicides per 100,000, the number of mental health beds per 100,000 population, number of psychiatrists per 100,000, and number of psychiatric nurses. And I put the majority of the Middle Eastern countries in contrast with 3 developed countries like the USA, the UK, and Canada. And I'll just pick, let's say Syria at that time. That was in 2007, before the war. So in the country of Syria, we had 0.8 beds of mental health beds for 100,000. We had half a psychiatrist for 100,000, meaning 1 for every 200,000. If we want to compare that to the USA, here we have 14 for the 100,000, meaning about 27. So between 1 to 27, you can see the stark difference. Even also in the supportive staff, the nursing staff, for example, you can see the differences. I mean, just the number speaks for themselves. So we have a huge gap between what is available and the suffering of the people in regards to mental health issues in the region. So what we did in 2015, we did a review and we published later of all the publications related to the use of telemental health. And the reason for that, and I can kind of guide you through my thinking process. I was looking at this and thinking, so, we don't have much manpower on the ground. And we already talked about, the poor infrastructure, the poor manpower, there aren't much specialists. And we have, an area that is bustling with technology. The technology use is not different than anywhere else around the world. Yes, the infrastructure can be better, but in the Middle East, people have iPhones and people have, they take the iPhone 7 off the shelf at almost the same time when it comes in the rest of the world. So there's this, accessory use of technology, but it hasn't been really implemented in ways to try to bridge some of this gap. So the idea of using telemental health hasn't been, it's not like a novel or a new idea. There has been some dabbling with it, and the purpose of this review that I'm sharing with you right now in the next few slides was try to see what is available in regards of reports, academic reports about the use of telemental health in the Middle East. So we reviewed all case reports, systematic reviews, opinion articles, clinical trials from the early 90s until 2014 when we published this. We found 12 publications. All of them were written in English. There's one written in Farsi. I had to ask and consult a colleague who was fluent to help us translate it. And we can say all of the publications fell into 4 main categories. Some looked at the attitudes of implementation of telemental health in the region. Some looked at the efficacy of the intervention, of some interventions, and I will go into some details into some of these, like interpay. I'll tell you what interpay. What interpay is: telehypnosis, telephonic psychoeducation, teleconsultation and supervision and training of healthcare providers, virtual therapy. So there was some efficacy trials. There were also studies concerning the alliance between the patient and the physician when the relationship is online. And then the rest fall under the general commentary of feasibility or challenges, so kind of more theoretical, like what challenges or barriers do we have to implementing telemental health in the Middle East. So most of our publication that we found fell into these four categories. So measuring attitudes, the main studies came out of Israel. We had, myself and colleagues, we did 2 studies in Syria. So those are the only ones that reported on attitudes of population, on a population-wide kind of looking into their acceptability for telemental health. There was a huge Israeli study, more than 1,400 subjects that were asked simply in a very simple study, what is your willingness to use technology if you're feeling anxious or depressed? On a Likert scale from 1 to 5, 1 meaning I'm not willing at all, 5 I'm extremely willing. And the main score was about 3.2, a mediocre, good, acceptable response from this population. There hasn't been, a lot of analysis on this data. It was a report, I believe, from 2006 from Israel. And then we did a study with the Syrian refugee population in Turkey, where we surveyed 354 patients in a primary care clinic. We asked them voluntarily to come and talk to us if they would like. There were people in the waiting rooms in a huge primary care clinic in Kilis in southern Turkey, where there's a major hub of Syrian refugees. Almost everybody spoke Arabic in this. There was a small sample of Kurdish population. We asked them, we had a small scale that looked into their psychological stress. But the main outcome of the study was we were trying to engage how much of them are interested really in, first of all, meeting a mental health provider in general. And second question was, how open are they to having the technology involved? So about 34% of our sample said that they feel like they need to talk to a psychiatrist or a mental health provider, but less than half of those 34% were really open to telemental health. The majority were saying, we really, would rather seeing face-to-face. They quoted a lot of reasons like, security of the internet. They felt like they could communicate better in person. Some of them didn't really know what the technology would entail. So there was a lot of educational and cultural, barriers to that. Which made us think that, if we have a partial acceptance to this, and we know that there are, at least in the Syrian context, which is really the area that I'm well versed with, given my work with the Syrian refugee crisis, we know that there are clinics that are providing mental health and medical care, and those clinics really do need support. So we thought, well, if we can try to gauge the attitudes into implementing telemental health as a way to support the staff who are already on the ground. Hence, the second survey that we did that is showing in this slide, that was a provider survey, meaning we surveyed about 60, not mental health, general medical providers and psychologists and social workers and nursing staff who are all on the ground in the Syrian context, working with refugees. And we asked them whether they think one modality of mental health, which is the store and forward, would be applicable and helpful in their practices, and it will be good for them and as a supportive way to help them manage people's mental health issues better. We had a very good response. It was about 77% of the providers were really willing to do that, and this will be the kind of work that I will guide you through in the last part of this presentation, and I will tell you a little bit about the rationale behind using store and forward, not video conferencing and all that. So I'm sure some of you started to have some questions about this, but I'll try to clarify all this in a bit. So this is just an overview of the literature available. The providers, when we asked them about their attitudes towards telemental health, they mentioned that cultural barriers are most likely to be an issue when implementing telemental health in their clinics. Financial issues, they were really concerned about, who's going to pay for what. They will spend a lot of time trying to struggle with the technology. Who is going to reimburse them for their own time? This is time that can be used in patients. And also, as we've witnessed 5 minutes ago, there are technical issues that are inevitable in doing this kind of work. Do we have support staff on the ground? Do we have people to tackle all this? So all of these are very real barriers into implementing telemental health in areas of the world that are considered resource limited in that regard. After the attitude assessment, the other category that we found most of the studies to look at are the randomized controlled trials or efficacy studies. And I will go a little bit quick on these. There were two intervention-based randomized controlled trials that looked at the use of technology in Iraqi refugees by Wagner et al. They selected Iraqi refugees with PTSD. They randomized them into treatment, and as usual, in a clinic versus the in therapy, which is internet-based CBT approach therapy. It's based on a Dutch manual of PTSD treatment using cognitive behavioral therapy. That was did a lot of very good cultural adaptation and studies leading up to this. And the bottom line is they found in two randomized controlled trials. The first one was just a pilot, very small sample, kind of proof of concept that they found that people who were randomized to the group of the in therapy, they were reduction in PTSD, depression, and anxiety symptoms, and improvement in their quality of life. So what the intervention entailed really was giving participants about 45 minutes CBT-based writing assignment where they would write it and send it to a provider who speaks Arabic, so everything was happening in Arabic, and write in Arabic, who will give them instructions on their assignments, who will discuss with them the, the discussion would be, try to, for example, the assignment will be, try to discuss, your thoughts about this, your feelings about that, how can you change your behavior about this? So they were kind of more of like written assignments. So this was not a live interaction. This was more of like a store and forward interaction between the patient on one side and the provider on the other side, who are exchanging CBT-based manualized treatment, which was found in this pilot study to be effective. And when they replicated it with a larger group, it remained effective, but they were also interested in the working alliance inventory or the online therapeutic work alliance. Meaning their main question was, you as a patient have been interacting with, over 10 sessions with a provider who you haven't seen in person, you haven't talked to in person, except for these assignments. Do you think you've developed a work alliance? And they were actually, to my surprise, there is such a scale. It's called the working alliance inventory that has been actually studied and validated in the 70s, I guess, or 80s, and even translated into Arabic and validated. So they used it and found that, people found, the patients found, the use of this technology to be really helpful. They found that they were working towards a common goal with the therapist, which is basically what the therapeutic work alliance is. The authors postulated that the anonymity of this internet-based program was actually a key to the success, given it's an opportunity really to overcome the stigma and the the shame that might be surrounding patients actually meeting in person with a provider in that culture, in our culture. So this is basically going to be the rundown of the 12 studies. I'm just going to go over them very, very quickly. This is adapted from a chapter in the book that's going to come out in mid-May. It's a book that I am the lead co-author with Andre, my colleague, and Eugene Augusterver from Harvard. The title of the book is Telemental Health and Resource Limited Global Settings out of Oxford University. I think people can go online and pre-order it. It's going to be up and they will start shipping the copies in mid-May. I'm actually excited to get my first copy from it. This is my first academic book that I dedicated to, talking about the applicability of telemental health and resource limited global settings. We have examples from a lot of many parts of the world, including the Middle East. So this table is taken from one chapter from that book. So basically, this is the study that I was talking about, the Wagner with the in therapy. There are a couple that I will talk about later that we were the lead authors. There was an interesting study done in Israel in 2006 about cost effectiveness of video conferencing. So they did a nice cost analysis study, because the other question would be, okay, that's nice on paper, this is great, technology can help, but is it cost effective or not? It's really depending on the setting. So in that setting, that's the only cost analysis reported in the Middle East of video conferencing in Israel, which one of the most developed countries in the region. So they had a randomized control trial where in the video conferencing part, they set up two campuses where on one campus they have the specialist and the other remote clinic, they have the patients come. And the control side, the specialist will actually drive to the remote side. So they calculated the costs involved in driving and loss of productivity and all that. And surprisingly, they found that while there were more adherence in the video conferencing group, and there was similar satisfaction in both groups, the video conferencing group had higher costs. So the technology group had higher costs than the face-to-face, which was really interesting in the study. So again, this is one study, haven't been replicated, but it can highlight that technology, even in the parts of the region that has better infrastructure, is still something costly. So it's kind of an interesting finding, actually. And then there was a study in Turkey that looked into family intervention and psychoeducation for patients after they're leaving the hospital, people with schizophrenia who left the hospital, and they used the telephone encounter as a way of tele-psychoeducation, and found that compared to a control group that didn't get the intervention, this telephone encounter really was helpful. So this is another example of the use of technology that has been reported in the area. Now, kind of this concludes the overview. I'm happy to get questions at this part, because the last part will be mostly about my work with the telemental health in the Syrian context, and one major example that I will go over in the next maybe 10-15 minutes. So I'm happy to take questions if you'd like about what we've covered. I know I've covered a lot of things, and I'm happy to clarify if there are questions.
Okay.
Can you hear us right now?
If I ask a question, can you hear me?
These are mics, so they should.
Oh, okay. My question has to do with the chart, the table that you put up. And I wondered what your thoughts were about, yes, why Jordan's rate is so much higher than the others. And I wondered if it was I believe that Jordan has a very large number of refugees. And I wondered if, is that because of suicide ideation and attempts among refugees, or what do you think?
That's a very good question. However, just keep in mind that this data is from 2007.
Oh,
So
okay,
at that time, Jordan didn't have much refugees.
okay.
My sense, it really has to do with the mechanism of um, reporting suicide. So because suicide in the region is dealt completely differently than it is in the U.S.
Yeah.
You have there is a lot of cover-ups. There's a lot of shame that involves the death by suicide. It's most of the time it's not reported as suicide death because the family do not want to, take on the shame of that, want to acknowledge it. So I think most of these reports here from in the Middle East in this were coming from the Ministry of Health records when they did this report. And it really depends on the forensic evaluations or the mechanisms of forensic reporting or documentation in each country. So I would assume that probably Jordan has a more rigorous forensic infrastructure compared to, I would say, Syria. I mean, 0.56. That does not make any sense. I mean, I went to medical school in Syria. I went to the hospitals. I know that suicide is a real thing. So 0.56 is not, it's not a real representation. This is what the Ministry of Health had in its report because of their mechanism of reporting suicide. So this data is really, I would say, it's really depending on the country, especially, and also the data about the number of psychiatrists. These are the number of psychiatrists who are registered in the health authorities or the Ministry of Health in each country. So you might have people who are practicing but maybe not licensed, or so all of these estimates should be taken in a grain of salt.
Yeah, great, thank you.
Unfortunately, yeah.
I just have a question that's also related, Hussam, if you can hear me okay?
Yes, I can hear you.
Just referring to that idea of stigma, I thought it was interesting that in your review you mentioned how rather than viewing this form of care as like not as good as face-to-face, it actually can circumnavigate some of those barriers to access. And it also just made me curious. For some reason, I was thinking about women as well, and in different settings, what their access might be, if there are actually interventions that you've heard of that would, be ideal for those populations. I know it's very broad. Sorry.
No. That's actually a good idea. I don't think I've read anything about intervention specifically for women because I would expect that women would be more open than men. Now, in our study, there was not a difference. And the study that, if you remember the one that I talked about, we surveyed 354 Syrian refugees in a primary care clinic. We had males and females. There was no difference in their acceptability to telemental health. As far as I remember, I can go back and look at the data closely. It's in the publication. I apologize, I don't remember whether there's been a difference. I can send you the paper for you guys to read after it.
Thank you.
But I don't think that there was a difference in openness between males and females. But in my clinical experience, I think females are more open to it because there's this kind of, traditionally women are not supposed to be, exposed. That's usually in the lower socioeconomic status women in the Middle East. They like to have the veil around them because of the cultural pressure. So having this doubled with the stigma against people with mental health issues, having this kind of secure anonymity of interaction with providers it can really be a big thing. But I don't think anybody has developed any interventions specifically for women, if that answers your question.
Oh, that's perfect. Yeah, that's exactly what I was wondering about.
Yeah, no, I don't think, I honestly, I haven't read anything recently, and I keep looking in the studies. I haven't seen any interventions that were developed, that tele-interventions that were developed in the region other than the Wagner. These are the last two interventions that were done in the region and studied in a research kind of methodological way. So there is a lot of work to be done. I mean, this is like, this is just a drop in the ocean of what is of what needs to happen if telemental health needs to be adopted in the Middle East. But again, keeping in mind the multiple barriers, the cultural, financial, the infrastructure, the legislative. I mean, you have to really kind of make a cultural change in the area to get that adapted.
Thank you.
Okay, all right. So I guess someone is knocking on my door. Just let me tell them. I don't know. Maybe somebody doesn't know. Oh, sorry about that. I was distracted by it. So so up until this point, my interests have been really in trying to bridge the gap in the Syrian context. We have millions of refugees. I'm not going to go over the data. You all know about the crisis. I've already written about a little bit about up until the development of this network. I've already written a little bit about the use of or the concept of using technology in or telepsychiatry in area of conflict, like the Syrian example. I've dabbled with using video conferencing in providing training and supervision to providers on the ground. And that's the first the paper here that I wrote in 2012 or 13. We had a lot of difficulties. I mean, the infrastructure, the quality of the video conferencing wasn't good. I haven't done any direct patient work because there are a lot of medical legal issues and uncharted territories that has not been clarified yet. For example, my medical license board here in the U.S., can decide that I have violated my license by seeing patients abroad. So it's really, it's providing direct patient care via video conferencing, cross limit or cross boundaries or internationally is really an uncharted territory that hasn't been studied. So in this paper here, that was my earliest encounters with the use of technology. I was just trying to help a provider on the ground who was struggling with a lot of cases of kind of complicated mental health presentations using video conferencing. So we were Skyping on a regular occasions, but again, the technology wasn't really sustainable. His time, the time difference was difficult. His time demand didn't really allow for sustainability of this project. And this is basically the study that I mentioned earlier about surveying primary care clinic goers in Turkey, which we tried to see whether now if we build it, would they go in a sense? I mean, if we build a system where we have addressed these medical legal issues and we can provide direct patient care remotely. While I'm sitting in the US, I can see patients, Syrian refugees in Turkey, for example. Would people come? And then actually I was stricken by this hesitance. Remember, less than half of the third who said they want to see a psychiatrist, less than half of those are actually open to the technology. So it's a really small portion and which made me really shift the way I think about the implementation of technology in this context and how it should go. So I'm not going to go over, I mean, we have a lot of mental health issues. So basically what we really were sitting and pondering on at that point, should we do something remotely or not? And if we do something, should it be something quick, fast acting? We can all go on a mission to Turkey and treat few refugees and feel good about ourselves. But that is, and so what? What is the long lasting effect of that? Or should we kind of think about something more sustainable, long acting, and we use technology to do something that is doable, sustainable, has an impact, and we can scale it up. So basically what we were thinking, okay, we have a problem. let's think about a solution and let's scale it up. Let's device the solution based on the settings that we choose to go in the area. It's a huge area. I mean, the burden of the refugee mental health right now is so great. We needed to start from a place and scale up, basically. So we found a partner, and I'm going to go briefly over this. We found a partner. It's under the UOSSM. This is an acronym of the United. I can't remember the acronym, but it's like the Syrian Relief Organizations. This is actually a French acronym. That's why it wouldn't make sense. But anyway, it's based in Canada. And they have a lot of presence in Turkey and inside Syria. And they have a good structure of clinics and mental health arms, plus medical and trauma release. So they were a very good partner for us to work with. We asked them, what is your problem in regards to mental health, and how can we help using the technology? So basically they said, well, we have a lot of clinics on the ground. We do have primary care physicians and we have psychologists, but we don't have any access to specialists. We don't have clinically trained psychologists. Our psychologists on the ground, they have a bachelor's degree from Syria, so it's not really a clinical degree, or a social work degree that is not a clinical degree. It's mostly theoretical, that they need a lot on the job training and they need a lot of continuing education. And this is something we thought with them that it will make a difference to kind of implement the technology in that regard. So again, that's why we surveyed the providers, as I mentioned earlier, and found that they're open. Oops, oh, sorry, here, that's, this is it. So they were like 77% of them found them to be helpful. So we worked with a platform that is, or that can be easily implemented in an area of disaster, in an area of kind of poor resources. And this is the platform that we have. It's a free platform. It's called Collegium Telemedicus. It can provide bases for telemedicine networks, including telemental health. In fact, Médecins Sans Frontières, Doctors Without Borders, they have the largest network. But it's not a mental health network, it's a medical network. So when we partnered with them to try to provide help to the UOSSM clinics, we were the first telemental health network that was formed on Collegium Telemedicus, which meant that we had to work a lot on adapting their platform. And I will show you actually the platform right now. I can log in as a coordinator and show you, what does it look like, working on this platform. So initially we did a small pilot in one clinic that is affiliated with the UOSSM. We worked through the feedback of the 4 clinicians that worked with us who were submitting cases from the ground. So the basic idea of the platform is you are a provider in a remote clinic, you're seeing patients with mental health issues, you need advice about how to deal with them. You'll go on this platform on your convenience, you will write up the case, you will put videos, you'll put audios, anything that can supplement your case, you'll send it to the platform. A coordinator will look at it and will send it to a specialist who is located anywhere around the world. And most of the interaction, all of the interaction actually happens in Arabic. So all of our specialists are Arabic speaking, who are either in the US or in Canada or in Europe. So after piloting it and working through the few kinks of, how was the advice that was given to you? Was it too general? How was it presenting a case? We gave them some also lectures about how to get mental health cases, like histories, how to, basic issues about treating, treating depression, managing psychosocial issues. And after the pilot, so basically our problem was lack of access of specialists. Our solution was teleconsultation and teletraining and telesupervision. we scaled it up by developing this our network, which is actually the main it's our main product at this point, which is the Syrian Telemental Health network. Currently, we have 19 clinics connected with us. The majority of them are through the OSSM, but we have clinics that we connect that are, either they are SAMS clinics, the Syrian American Medical Society, or they are, grassroots organizations inside Syria or in the neighboring countries, whether in Jordan and in Lebanon. We have, from these clinics, we have 47 referrers, that meaning these are clinicians on the ground that are putting the referring cases for advice and supervision and long-term management. And we have 18 specialists from different specialties: psychologists, psychiatrists, child psychiatrists, addiction, neurologists. And thus far, we have about 133 cases allocated. So let me, maybe in a minute, I want to show you, I know we're almost out of time, but I want to show you the, basically the platform. So I'm going to log in as a coordinator. So I can show you our users. We have a lot of specialists. Some of them are available, some of them are unavailable, from the United Kingdom, from Turkey, from Canada, and we have the referrers, which are about 47. Some are active, some not. The active ones are about 17. Some of them are inside Syria, some of them are in Turkey. Let me show you just a brief example of how a case would look like. So let's say this is a recent case. So basically, a case will come in. It's everything is in Arabic, and it's usually there is a attachment of either an audio or a video for part of the encounter or for the concerning part of collateral information from the family, especially with children. So basically, the idea is the person on the ground, on their own time, on their own initiative, kind of identify cases that they're really struggling with, that they're treating and they're struggling with. They don't know how to go forward. They don't have any supervision. The closest specialist psychiatrist is about 400 or 500 miles away in a different country. So they go online and they put it through the system, and we allocate it to a specialist who will be assigned to the case, and we'll kind of have a back and forth kind of discussion using this simple platform. I'm not going to go over the data. Our challenges mainly are administrative management, remotely, how to engage more clinics, how to keep the clinics engaged. Most of our clinics were inside Syria in the 2014 and 15, but during the shifting war that happened and the advance of ISIS, unfortunately, a lot of those clinics were destroyed. So we had to reestablish care with new remote clinics that were built. So it's a fluctuating work process. And my main question would be really, and which I'm trying to see if we can measure, is how can we study the impact of this? How can we study really this increase of capacity that we're hoping for the providers on the ground who are engaged with us using the technology? One of just next step that we're very excited right now to have an app for it that people they can log in. They don't have to have a computer, everybody has a cell phone, so our referrers and people on the ground, they have a cell phone. They can log in on the app. They can refer the case while they're sitting there. They can record video or audio, of course, the patient's permission, and send it to the network. So we're very excited about that. The progress. I mean, we've been talking about having an app for the last 4 years. So you can imagine this is not a funded work. It's all volunteer. Even the coders are volunteer. They're based in the UK. So it's a very slow process, but it's going there. Again, this is the book. I hope, I hope it will be helpful for people interested in this particular niche of implementing telemental health in resource limited global setting. And this concludes my talk. I'm sorry I went over time. I would like to make sure that I answer any questions or whoever remains. I don't know if you guys are still there or you have to leave.
Well, Hussam, congratulations on the book. And
Oh, thank you.
we'll certainly look at adding to our library. One thing I noticed is, and you described social workers as not being clinical, whereas here in the US, the majority of social workers, and in fact, the majority of mental health involves, social work clinicians. So do you see that changing, or we just look at, okay, psychiatric nurses are fulfilling that role because it's the training and specialty?
Yeah, I mean, and unfortunately, even during my training in med school, um, the role of a social worker is not clinical in Syria. I mean, that's how it is over there. There is really, in a way, no role for a social worker, which is, I think it might be changing nowadays. I mean, I haven't been back home, the area in 10 years, but still, there's a long way to go. Um, Even for nurses, I mean, even psychiatric nurses, they're not really well utilized and they're not well trained. Psychiatrists are not well trained. So I mean, that's one of the reasons why I came to the US to get trained as a psychiatrist. Is I wasn't going to be satisfied with the level of training I will get there. So the whole field of mental health, where social work is really an integral part, is not recognized educationally, and especially the social work and psychiatric nurses. Their role is very, very limited clinically. So these degrees end up being theoretical degrees. Unfortunately, with very, very limited clinical training. The folks we work with on the ground who has a bachelor's in psychology from Syria that are now displaced, and they work with some of these clinics that we support via the network. They haven't seen a single patient during their 4 years of college. I mean, it was purely theoretical. So if you want to do a master's, then you do an additional 2 years, but very few people do that, and people end up either working in something completely unrelated. And so there's like this educational system has really to adapt, and this is a huge undertaking. But yeah, I agree. I mean, we don't, the role of social workers is not clinical at all, unfortunately, especially in this setting. I mean, I think from a trauma perspective and displacement and being a refugee, you need a lot of social support. I mean, that should be the first main area to address is how can we support, how can we take care of your basic needs. Are you connected with your family? Are you having a housing? Are you, do you know what services available? And this is part of the psychological first aid kind of training that we try to teach everybody. Is there are psychosocial interventions that needs to happen way before we go on to the more advanced trauma focused or whatever it is clinical work that we need to do.
Thank you.
Sure.
I had another question, Hussam, about you were talking about the limitations of going across a border and having your certification be challenged because of doing that. And I recently had some friends who, I think it was through SAMS, Americans who went and one worked in like a dental clinic and one was a surgeon for a brief period, I think, in Jordan. So in those cases, it seems like, I don't know the details of what they had to do, but their certification was still intact.
In that case, it's easy, actually. If I want to go in person, I will be covered under the disaster relief law. Actually, if it's actually doing remotely, because I'll be sitting in Massachusetts and treating a patient, in Turkey or in Jordan, that is the perceived violation that the medical legal body hasn't really resolved, is because basically I should have a license where the patient is at.
Okay.
I should have dual licenses, and I should be permitted by my licensure board here to practice in Massachusetts and seeing patients outside, which is really complicated. But when you go on a mission, you're actually you're more protected under the relief, kind of disaster relief. There's an umbrella of medical legal exceptions if you're going to a refugee camp or whatnot. So, but those interventions, again, I have all admiration and support to everybody who's doing this, but usually they lack sustainability, and this is one of the things that I wanted to shy away from, or try a different approach.
Well, I think
Any other?
I think
Yeah.
we're about out of time.
We are way over time, actually.
Yeah.
I think for the opportunity.
Most everyone is here still, so we have a good audience here.
Yes, awesome. Thank you, everybody.
Thank you. That's great. Very much.
Please stay connected. You have my emails. Please hand out my email. For those who are interested, I'm happy to talk more. And yeah, thank you for this chance.
Thank you.
Okay.
I can everyone who signed in today, if you want his, I can send out an email with his contact information.
Great.
Speaking of signing in, make sure that you're signed in. That's how we pay for the lunch. So